associated symptoms, what preceded the symptoms, any history of such as low infection, fever, any headache, vomiting, any other systemic symptoms. When was she discharged from the hospital? Did she get any medication to take home? Like how complicated was the postpartum while she was still in the hospital? Were there any issues there? On past medical history, specifically for conditions like issues and epileptic patient, if she's taking any drugs, medication, and also on further social history, social habits, if she's using any drugs, and also history of injuries as well. Also exclude trauma.
Just remember, you want also more details about the delivery itself. Gestational age she delivered at, what are the circumstances around, anything that could have precipitated the preterm delivery. Okay, just don't forget about those details. Okay, let's go on.
Okay, the history, she grew at 17 weeks gestation. The RH was positive, RPR was negative, HIV negative, and HB of 11.7. She had 4 clinic visits with no reported complications or adverse events. She is not a known mental health care user, no history of medical condition or previous admissions, no surgical history or previous head trauma, presented at 30 weeks gestation with low abdominal pain, spontaneous rupture of membrane, and anyone maturation. So she received steroids and delivered a 1,260 gram 24 hours after presentation. The perineum was intact and the placenta was complete. Patient was given injectable contraceptives and was expressing for baby. Patient was awaiting baby to be discharged from nursery. Day 8 post-delivery, the patient started talking to herself, pulling other mothers' blankets off them and being disruptive. She had paranoid delusions. She believed she was being bewitched. She was incoherent. She had incoherent logical speech. Started hearing voices of her aunt and gradually started seeing the aunt in the ward. Symptoms, she started, there were no depressed mood, no suicide ideation. She had problems maintaining sleep, no diet, no change in diet, and no anhedonia, sorry. And then there were no symptoms of meningitis. So collateral history was taken from the father. The mother had passed on. Daughter is unmarried. First presentation, confirmed no history of medical conditions and surgical conditions. Confirmed no history of head trauma and confirmed no previous admissions. Also confirmed no received drug use. There's no family history of mental health conditions. She repeated grade 10 twice and passed matric at the second attempt. She has an unemployed and unsupportive father of the child.
Okay.
How would you examine the page?
Is my son spoken?
Not yet.
Just that I,
Oh,
just like
There's a patient with auditory and visual hallucinations. Day 8 post-delivery.
Firstly, just look at the general appearance of the patient. She kept, wearing the hospital attire, it's okay. And then check the BMI, the weights and heights, just have an idea of the BMI. And then from there, I'll do the vitals just to check the blood pressure, pulse, respiration, and the temperature. And then just a head to toe examination quickly. Look at the breasts, they're okay, no engorgement. The baby is in nursery. abdomen is well, it's just well involuted, just a quick exam, and then the mini mental state exam, just to check if she's having any, in terms of the speech, if the speech is fine, and if the affect is there, it's okay. Ask about these hallucinations, find out if she want to act on those hallucinations and all that. Yeah, if she has any suicide ideation, also that we've gotten from the history.
Okay, so a lot of your mental state exam will come from your
From the
history.
history, yeah.
Just focus on clinical exam now. What specifically would you be looking at? So you know you have to formulate some sort of mental state for the patient, looking at your appearance, attitude, behavior, all those things. But clinically,
Clinically, I don't also exclude any general medical conditions that can cause this kind of symptoms. So
Okay.
any signs of mechanism, check.
so you'll focus on which parts of your examination.
Okay. CNS, just exclude mechanism.
Okay,
Neck stiffness or any other signs like this sign or those.
right.
Yeah, I don't think there's any other medical condition that I can think of to put this psychiatric symptom, which is devastating.
Okay, anything else you want to add? Next to Dr. Malik.
Okay, on the general examination, I think we check if the patient has any fever, she tachycardic, because we also want to exclude any condition that might bring sepsis post delivery. We would also examine the respiratory system, listen to the chest, and check if there's anything that she might have, like maybe pneumonia. And then the abdomen, we would also look if she delivered normally. We will also check if there's no any abdominal distension, if the abdomen is soft. And we will also check if there's no erythema also on the skin, on the abdomen as well. And then for the genital system, we would examine, we will look at the cervix, we'll use the speculum and check the condition of the cervix as well. Because if maybe she's got a concurrent sepsis, that might be causing psychosis, we would need to exclude any condition that the uterus might be having problems as well.
So you have to examine all systems, right, including the abdomen and pelvis.
The examination, the patient was comfortable on the bed. We had poor eye contact and was anxious. She was not orientated to time, person, and place. She had a conjunctiva, no jaundice, 8 pyrexal to touch with the average BMI. Blood pressure was 123/63 with a pulse of 82, temperature of 36.5, and a respiratory rate of 22. She had a normal thyroid and breast exams, the breast was lactating. The respiratory system was clear with good air entry bilaterally. Cardiovascular had normal heart sounds, no additional sounds at the moment. Abdomen was flat, no surgical scars, well contracted, 16-week uterus, no tenderness. And pelvic exam, speculum was a pink. She had normal external genitalia and vaginal walls. Pink normal cervix, lochia was normal, and there was no foul odor. By manual exam, she had a bulky postpartum uterus, no product of alcohol. And then CNS exam, as of Coma scale was 15/15. She was not orientated to time, place, and person. There was neck stiffness. There was normal reflexes and power, and global increased tone. Lower limbs, there were no signs of DVT. The skin had no signs, there were no rashes or lesions. And at the mental state exam, she was kept in hospital attire, no abnormal movements, incoherent illogical speech, flat affect, auditory and visual hallucinations were present, and she had poor insight and judgment. What are the possible differential diagnoses?
Two of them you've already alluded to.
Acute psychosis secondary to a medical.
I can't hear.
Sorry, acute psychosis or psychotic episode secondary to an acute medical condition.
Okay, so psychosis due to a general medical condition.
Postpartum.
Okay,
Postpartum.
Postpartum.
Parapsychosis, yes.
What else goes with that? Postpartum depression.
she didn't have any mood symptoms, so unlikely. Not to say that you can't have psychosis that goes with a mood problem, particularly depression, but she had no mood symptoms.
Yeah, no what? Mood.
Mood, yeah, so depression,
Oh,
mania, those types of symptoms,
Brief psychotic disorder.
right, with postpartum onset. Right, so brief psychotic disorder is within a month, right? So 1 month. So brief psychotic disorder with postpartum onset. Remember, we did a full clinical examination to check for any source of sepsis, because sepsis can also cause a delirium and then they present with.
you did say it's neck stiffness, isn't it?
So that will fall under psychosis due to a GMC,
Did you what?
general medical
Yeah,
condition.
yeah, yeah.
Okay,
She still could be schizophrenic. We don't know. You still, although there's no past history, we don't know. Because where did you get the history from that she is not schizophrenic?
father, collateral
Father.
history, yes. Collateral.
Oh,
So the possible differential diagnosis, you have a successive delirium, psychosis due to a general medical condition, and a brief psychotic disorder with postpartum onset. How would you investigate this patient?
Online, do you have anyone?
don't worry about the online.
Leave the online. And try you.
So we want to rule out sepsis. So I would do, she did also have urinary symptoms. So you would do your urine dipstick, you would send urine off from MCNS. I would do a full blood count,
Looking for, just say for blood count, looking for this.
Okay, so I do a full blood count, particularly looking at the white cell count to see if it's elevated, and a CRP and procalcitonin, which would also help with determining if there's sepsis.
You know, GT sitting here, he tells you,
You
don't, please
put
don't
the
do.
CRP and procalcitonin at the same time.
He's sitting here.
I'd say I would go first for procalcitonin if possible, because it's a better marker for bacterial infection. I would.
But was she parental?
No.
Sorry?
Is she parental?
She's not pyrexial.
The log here was normal, not so where your sepsis comes from. That's your first.
Okay, yeah, no, she also has neck stiffness, so she's, yeah.
And then we're not thinking she may be uremic, so like I wouldn't need a UNE at this point in time. I would consider, based on the neck stiffness, a lumbar puncture if we've excluded any focal neurology and she is GCS 15. There's no contraindication to a lumbar puncture. I would do a lumbar puncture, and we didn't think of her chest was clear and her abdominal and cervical examination was normal, so I wouldn't consider a chest X-ray at this point in time. But we're thinking meningitis, so a lumbar puncture.
Okay, so remember you can get TB meningitis.
So, so then sputum.
Anyone else want to help? Doc, that just joined us. Got a patient post-delivery, day 8, auditory visual hallucinations. Clinically, she's just got some neck stiffness and otherwise examined well.
I would confirm also, so the booking plans are normal.
Yeah.
So besides the full blood count and the she has some psychiatric symptoms, so you need to exclude organic causes, other organic causes. So urine electrolytes to see if there's any electrolyte abnormality.
Okay.
We check the HP and the white cells. Okay. We can also do like a B12 and folate. In terms of the blood, consider imaging as well.
Okay. What imaging? Okay. Any other thing that you may want to repeat? Okay, so it was only done at booking.
That's been HIV.
Okay, so ideally you should be repeating HIV and repeat your syphilis testing. Yeah.
On the electrolytes, just to the common things that we can.
You're whispering now, Madeline.
Like calcium phosphorus.
Mhm.
So add that on the electrolytes.
Any other endocrine issue that gives you psychiatric symptoms? All right, so you need to do a thyroid function test as well. Okay, since we mentioned an LP, I know it's long since we've gone through interpretation of lumbar puncture, but specifically what would direct you towards a bacterial meningitis, viral, TB?
So with your viral meningitis, usually you have lymphocytes, lymphocytes versus mistaken, and your glucose won't be affected that much. But with your bacterial, you have polymorphonucleosides, which will be elevated. And with things like TB and fungal infection, we have low glucose because they're living organisms, so they consume the glucose.
And high lymphocytes,
And high lymphocytes.
the TB.
Investigations that were done, bedside we did a dipstick, which was normal, glucose was normal, and blood gas was not done. FBC was done, white cell count of 15.14, HB of 10.3, sodium of 137, potassium of 3.3, which is a bit reduced. Chlorine 104, urea of 1.6, and a creatinine of 47. RPR was treated, it was positive with titers of 32. CRP was 61, then ESR of 19, so they were elevated. Magnesium, calcium, magnesium, and phosphate were normal. LFT was normal, and the thyroid function was normal. Hepatitis studies were negative. HIV test repeat was done, it was non-reactive. Then folate were urine and CNS, there was no growth. Urine LEM was negative, and the lumbar puncture, fluorescent treponemal antibody absorption was positive, which indicated that she might have syphilis. Gene expect on the lumbar puncture was negative, the glucose of 3.5, protein was 0.2, and elevated neutrophils. Then the general swabs were done. What was not the problems of in
LP and the rest of the blood investigations were done.
Sorry, who gave the consent for HIV?
Was it not done in antenatal?
It was
No, it
done.
was repeated now.
Oh, I see.
Who gave the consent? The patient? I'm just trying to find out in my own mind, should we be doing HIV without the patient's consent? That's what I'm trying to, I don't have an answer. I'm trying to see, should we be doing it without the patient's consent?
I think you can,
You can.
because you're doing all these other tests without their consent.
No, the other tests don't need consent. HIV needs a consent.
Why?
Huh?
You need consent for all tests.
It has different.
No, it's
She's been having, probably, she was booked patient.
Yeah.
She must have had a lot of HIV tests all the way through. She gave consent.
That won't hold water, Dr. Moren. For every procedure you do, you take consent, especially when it's got you can't just.
She's had a lot of procedures here. LP, did she have consent?
Yes, she would not have cooperated. She may not have written it down, but she cooperated with the LP. LP doesn't need your cognizance for long term, but this one needs your cognizance for long term. The fact that I've agreed to an HIV test before doesn't mean that I want to do it now.
It was just a spanner in the works, something that we need to think about. I mean,
Why are you saying this? Are you saying we have to hide HIV testing now?
I am just saying because I don't want registrars to walk out of here under the impression, I agree with Dr. Mike, under the impression that just because I consented before and I then have and that would be a wrong message. We have been taken to court for this HIV story, whatever. It's got long-term implications, mental, whatever. And LP, yes, maybe I'll injure your nerves at the back and whatnot, and all of that. But it doesn't mean that because I've agreed, that will be a wrong message, especially in a teaching platform, that just because a patient has consented to a procedure, you're going to do it again.
What about syphilis testing? Syphilis was done.
It was, but we have never been taken to court for syphilis.
no, it's not a court story. You know, it's just the HIV, as I'm saying, as Prof is saying, has got long-term implications. And there are patients that don't want to know their HIV status. So the only reason I was just asking is we need to be cognizant that we need to be asking somebody to do that. To do the FBC and all that, you don't even ask the patient, you just will do some tests, because obviously it's got very little implications in terms of that. But the HIV can lead to a number of implications. That's the only reason I was asking that question, to say, do we have a leg to stand on or not? And unless we ask a little bit widely, we might find ourselves short in terms of that. That's all. That's the reason for the question.
Pointing.
So this would be just that.
Sorry, can I just ask a question? Can
Sure.
you just go back to that? So, sorry, I missed the first part. She was syphilis negative, antenatal?
Yeah.
So when was she tested for syphilis? Because there's a schedule of testing for syphilis during antenatal. Do we have clear documentation of when those tests were done?
So she had 4 visits at the clinic and none of those visits had a repeat.
None of those?
Visits had a repeat.
The last visit referable to the delivery was when? Do we know when the last visit was referable to the delivery? The last visit vis-a-vis the date of delivery. Can't remember. Okay. And
But she had 4 visits, but the test wasn't repeated.
And at delivery, was she tested?
Where did she deliver?
At Mahatma Gandhi.
So
Yeah.
do you not have a protocol of testing?
So we do. They have a RPR rapid test, the combination, if they're HIV negative, in labor ward at.
So was it done?
So was it done?
It was done. It was
It was negative.
I don't believe it was done and it was negative, because it can't be RPL 32 1 week later.
Funny enough, I've had another patient who also had rapid negative, but baby was congenital syphilis. Did the titer on the mom, was positive.
So it's a false negative.
Then we need to investigate that batch of tests.
Just to verify that, we've also had the clinics complain about that, as well as our staff here, is that we've had the rapid being falsely negative and the RPR being positive.
Yeah.
I think that since we put that thing out where we've gone according to the protocol about where you procured, because I think some of the clinics are finishing what stock they had and may not have procured the test. Since we've got the accredited test, that seems to have reduced, but we do get the occasional patient. And you can have the program, we get a false negative, although the TT may be high. So it's just something that we have picked up that it has happened. Also, there's also for me is the human side where the person doing the test may incorrectly interpret or do even though basic. And I think that's one of the areas that I think we are same like what the RH, some people do misinterpret.
No, because to me, it's a big problem if we missing that diagnosis, let's say in the hospital at delivery. If you're doing the test, it can either be that the test is expired or has been kept in inappropriate conditions, like sitting on a windowsill in the sun. Secondly, it can be read wrong because they're instructions. And I think sometimes people are very quick to look at the result.
Yeah.
The actual instructions will tell you should read it after 15 minutes.
15 minutes, yeah.
And thirdly, they have to put the right number of drops of the reagent onto that sample. So all those things maybe need to be looked at because otherwise it's a problem if we're getting wrong results.
Yeah, I think we'll just glance over this because we did talk about it because it's got a long presentation as well.
So what is the most likely diagnosis?
Okay, we know it's
NeuorSyphilis, psychosis due to gender.
okay. What stage of syphilis would she be? What primary, secondary, tertiary? I'll say tertiary. 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 No whispering.
No, I was also thinking it's secondary to syphilis because of the acute. She was not a known patient with syphilis. So she just had high titers. So that's why I was like, but it usually NeuorSyphilis is under tertiary, unless it's syphilis with delirium, like acute.
It's actually secondary. Right. So primary is just the painless ulcer, which then resolves within 2 months. Should I give this to you? Right. Secondary. Then you've got the symptoms of the palmar rash, fever, weight loss. They can have then psychotic symptoms or symptoms of a meningitis, condylomata lata. Those are all part of secondary. Okay. Then you go through your latent phase, early latent, late latent. Tertiary is now we're talking years after untreated syphilis, years, not acute, right? So then you've got your paresis, your tabes dorsalis, and your gummatous formation. So this is secondary.
How would you manage the patient?
Sandra, let's make some big progress now.
Is that NeuorSyphilis?
Yeah. Yeah, so the treatment now should be to try and treat the syphilis with penicillin.
Okay.
And we have to.
Is it the same as the outpatient treatment? Any idea? We had to look it up.
Yeah, yeah, I'm sure it's
Dosage regimen.
some of the regimen, how to fix it, something that I'll have to check, yeah.
Okay, so management with penicillin, what else?
Then also the symptoms, the psychosis, we can probably give antipsychotics for that. That's be done pretty dope. Then I think we'll have to discuss with the psychiatrist.
Right, so you will enlist the help of a psychiatrist, okay? What else? So management of the psychotic symptoms, the syphilis itself, the medical condition.
Social.
All right, so you need to assess the support structure. We want the social worker to then also investigate any other stresses at home that may be contributing. Yes, pediatricians. Why? Because you've got a mom that's positive. The baby may not necessarily have had symptoms at birth, but they do need to test baby.
Contact tracing.
Contact tracing for the partner.
Once the mom is apsychotic or has some insight into her condition, counsel on the diagnosis.
Yes.
Long-term consequences and that you
Oh, my hearing is so bad.
sorry, counsel the mom once she has some insight, so the psychosis has been managed on her diagnosis and the consequences of syphilis, that she can be reinfected and how to prevent future infections.
Okay.
You mean you're counseling her about that, or what do you think?
Once she's baseline has some insights, so long term.
Just the contraception.
Yeah, she had Depo-Provera post.
The potassium was also 3.3.
So
the management is a multidisciplinary approach. Physicians, psychiatrists, obstetricians, neurologists, radiologists, and pediatricians, as you can. It's usually managed as an emergency, and you assess if the mother can be with the child. So in this case, the patient was a bit disruptive in the ward. So she did need a bit of sedation. We can give antipsychotics. Can initiate with haloperidol 0.75 to 1.5 milligram daily and can be titrated to 5 milligram daily, or risperidone 2 to 4 milligram per hour, to a maximum of 6 milligram daily. If there's a risk of extrapyramidal side effects, and this was by the National Department. This treatment is still benzyl penicillin, IV 20 million units daily in 4 to 6 divided doses for 10 days. This is by the Department of Health. And extensive counseling of the patient and the family, and then a social worker to determine or ascertain family support of the patient.
okay. First NeuorSyphilis. Go on to presentation.
That's quite a very high dose and intramuscular. Can you imagine you getting 4 injections?
Intravenous.
Intravenous. Oh, I was just about to ask what happened to protein.
Yeah, IV.
Okay.
So Dr. Mole has covered psychiatric conditions as well as syphilis in his presentation, so he's going to go quickly because of the time.
Okay, so we're going to be dealing with the perinatal psychiatric disorders and NeuorSyphilis. So the outline of the presentation is as follows: introduction, epidemiology, prenatal evaluation, pregnancy effects on psychiatric illnesses, risk factors, specific conditions, and NeuorSyphilis. So the pregnancy, childbirth, and postpartum period are a significant period in the life of a woman and those in her life, and necessitates adjustments to their lives. Changes brought about by the journey of pregnancy and its adjustment increase the risk for new mental health conditions in women and relapse of pre-existing mental health conditions. Unplanned pregnancies, miscarriage, and experience of a traumatic or unpleasant delivery have all been linked to significant risk of developing depression after delivery. 10 productive years are the most likely time for a woman to experience psychiatric illnesses like anxiety and mood disturbances. 15% of women in the childbearing period receiving prescriptions for antidepressants. Post-delivery, 1 to 2 in 1,000 women are diagnosed with postpartum psychosis and bipolar disorder. Mental disorders need early detection and management as they can affect the mother-child relationship and result in adverse pregnancy outcomes. Most women present in the postpartum period with maternity blues, which is self-limiting, and postnatal depression. 10% of pregnant women and 13% those post-delivery will experience mental health disorder, primarily depression, and it's higher in developing countries at 15.6% in pregnant women and 19.8% in post-delivery. Anxiety disorder has a prevalence of 15.2% during pregnancy and 9.9% in the postpartum period. Post-traumatic stress disorder has a 4 to 6% prevalence and higher in women with negative pregnancy outcomes. It's also found to have a prevalence of 10% until Italy and 5% in the postnatal period. Locally, the prevalence of perinatal depression, stress, or anxiety range widely from 16 to 50%, and a further 10% are at high risk of suicide during the prenatal period. Prenatal evaluation. Pregnancy is a risk factor for mental health illnesses. Prenatal screening for mental health illnesses should be done to ascertain current conditions or risk for their development. So current symptoms are use of psychoactive medication, previous hospitalization, and family history of mental health disorders. Patient with an established mental health or previously diagnosed may relapse if medication is stopped during pregnancy. Relapse rates following the discontinuation of antipsychotic medication are high and doubled in the short term if the medication is stopped suddenly rather than withdrawn in a tapered fashion over 3 weeks only. Risk factors should be evaluated, that is stress, unemployment, unsupportive relationship with partner, and previous pregnancy loss. A prior personal or family history of depression is a significant risk for recurrent depression. Women with a history of sexual abuse, negative life events, physical and verbal abuse before and during pregnancy are most likely to have depressive symptomatology. Substance abuse, violence, and depression are also linked. In addition, because eating disorders may be exacerbated by pregnancy, affected women should be followed closely. So this is the current screening tool used by the new maternity record. So it has a score of 3, with the last one, the third one, needing a referral. So in the last 2, you ask the patient, in the last 2 weeks, have you on some or most days felt unable to stop worrying or overthinking too much? If they any yes answer scores 1. In the last 2 weeks, have you on some or most days felt down, depressed, or hopeless? In the last 2 weeks, have you on some or most days had thoughts and plans to harm yourself or commit suicide? So the interpretation of it is as follows. If they answer number 3, which pertains to suicidality, you refer them to a mental health doctor or nurse. If they answer yes to any of the first 2, they can be referred for counseling. So pregnancy effects on psychiatric illnesses, both biochemical factors and life stressors influence the onset of mental illnesses in pregnancy. Hormones are known to affect mood, as evidenced by premenstrual syndrome and menopausal depression. Estrogen modulates serotonic function and has been used therapeutically to treat depression. It may be a factor in the mood elevation experienced by women during pregnancy. Corticotropin releasing hormone, which is usually elevated in pregnancy, is present at lower levels in women with pregnancy-related depression. The absolute hormone levels and their rate of change also appear to be influential. Women who experience postpartum depression often have higher pre-delivery estrogen and progesterone levels and experience a greater drop to levels in the postpartum. Factors that protect against the onset of mental illnesses in pregnancy and the epithelium are the mechanisms that the woman usually uses to cope with life's physical, psychological, and social stressors. Significant factors include continuous emotional support in education with regards to pregnancy, childbirth, the postnatal period, and baby care. So awareness is key. So some of the risk factors, some but not all, are teenage pregnancy, chronic medical conditions, poor support or poor relationships, unwanted or unintended pregnancies, trauma, intimate partner violence or domestic violence, and substance abuse. We have past psychiatric history, being a refugee, asylum seeker, or a displaced person, previous or current pregnancy adverse outcome, such as stillbirth, miscarriage, or neonatal death, maternal physical impairment, fetal congenital defect, poverty and food insecurity, and hostile in-laws. So the specific condition. So the classification currently, or the criteria used, we use the diagnostic and statistical manual. In its current version is the DSM-5 text review that was from 2022. It's written and periodically updated by the American Psychiatric Association. Its purpose is to establish as to assist in the classification of mental disorders, and it specifies criteria required for each diagnosis. It does not have a specified separate criteria for pregnancy and uses the already established criteria with onset during the prenatal period. Any psychiatric disorder may occur during pregnancy. So mood disorders, we have a major depressive disorder, a major cause of morbidity in the 21st century. Major depression is multifactorial, prompted by both genetic and environmental factors. Prenatal depression is an extremely strong predictor for postnatal depression. Depression is more likely to occur with marital problems, unwanted pregnancy, personal or family history of depression, and low socioeconomic status. Depression may be linked to increased risk of preeclampsia, possibly due to the altered regulation of vasoactive hormones as a result of depression. Bipolar mood disorder. Affected individuals have manic episodes defined as a distinct period during which there is an abnormally raised, expansive or irritable mood, self-inflicted, self-esteem or grandiosity, decreased need for sleep, pressure to keep talking, flight of ideas, distractibility, and increase in goal-directed activity. Bipolar 1 disorder is characterized by one or more episodes of mania with or without a major depressive episode. Bipolar 2 disorder is characterized by one or more episodes of hypomania as well as at least one major depressive episode with no psychotic features. The periods of depression last at least 2 weeks. About 10 to 20% of patients with manic depression commit suicide, and major mood disorders contribute to 2/3 of all suicides in the United States. Schizophrenia. So the 4 major subtypes of schizophrenia are recognized, which is catatonic, disorganized, paranoid, and undifferentiated. Diagnosis in terms of DSM requires the presence of 2 or more of the following characteristic symptoms: delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, negative symptoms such as social withdrawal or loss of motivation, social or occupational dysfunction. Patients with schizoaffective disorder have a chronic deteriorating psychotic disorder like schizophrenia, but combined with prominent mood symptoms. Although the psychosis really abates, the mood symptoms often improve with therapy. anxiety disorders. Approximately 1 in 10 pregnant women will suffer with an anxiety disorder in pregnancy. Examples of these relatively common disorders include panic attack, panic disorder, social phobia, specific phobias, obsessive compulsive disorder, post-traumatic stress disorder, and generalized anxiety disorder. All are characterized by irrational fear, tension, and worry accompanied by physiological changes such as trembling, nausea, hot or cold flashes, dizziness, dyspnea, and so on. The preferred treatment for all these conditions is cognitive behavioral therapy, goal-oriented psychotherapy. Medication influence selective serotonin reduction inhibitors, antidepressants, monoamine oxide inhibitors can be used as adjunct to cognitive behavioral therapy. Personality disorders. So these disorders are characterized by the chronic use of certain coping mechanisms in an inappropriate stereotyped maladaptive. American Psychiatric Association recognized 3 clusters of personality disorder. There's paranoid, schizoid, schizotypal personality disorder, which are characterized by oddness or eccentricity. Histrionic, narcissistic, antisocial, and borderline disorders, which are all characterized by dramatic presentations, along with self-centeredness and erratic. We have avoidant, dependent, compulsive, and passive-aggressive personalities, which are characterized by underlying fear and anxiety. Genetic and environmental factors are important in the genesis of these disorders, whose prevalence may be as high as 20%. Although management is through psychotherapy, the majority of affected individuals do not recognize that they have a problem, and only about 20% secure. So these are some of the postpartum disorders. Mental illness that occurs in a woman within 90 days of childbirth is generally considered to be postpartum. So you have postpartum or maternity blues, postpartum depression, and postpartum psychosis. Postpartum blues, following childbirth, 50 to 80% of women experience a mild elevation of mood, and that is followed by a variety of variable severe lowering of mood, which lasts 3 to 5 days. The predominant mood is happiness, but they are more emotionally labile with insomnia, weakness, depression, anxiety, poor concentration, irritability, and affective lability, and may be associated with difficulty in breastfeeding or other complications for the patient or the so management is usually self-limiting, results rapidly and spontaneous. Emotional and practical support, as well as help and advice to restore confidence. Sufferers can be reassured that the dysphoria is transient and most likely due to biochemical changes. They should be monitored for development of more severe psychiatric disturbances. So it's a high incidence of postnatal depression. And they may require treatment with benzodiazepines. Postpartum depression. According to the National Mental Health Association, postpartum depression develops in 10 to 15% of women following delivery, usually within the first 4 weeks. Symptoms, they have depressed mood, anhedonia, increased anxiety, sleep difficulties, feelings of worthlessness and incompetence, suicidal ideation, patient is unable to cope with caring for self, and there's difficulty in concentrating and making decisions. And then there's a Edinburgh postnatal depression scale or postpartum depression scale can be used to evaluate the risk and the depression. So symptoms must be present every day for most of the day for 2 weeks. Surveillance should also include monitoring for thoughts of suicide or infanticide, emergence of psychosis, and response to therapy. Up to 70% of women with previous postpartum depression have a subsequent episode. Women with both previous puerperal depression and a recurrent episode of bliss have the chances of developing a major depression increases to 25%. So the management usually as follows. We use selective serotonin reuptake inhibitors in the area of fluoxetine 20 to 60 milligram daily, citalopram 40 to 60 milligram daily, and paroxetine 20 to 60 milligram daily. We have tricyclic antidepressants, triptyline 25 to 300 milligram daily, nortriptyline 50 to 150 milligram daily. And then you have your serotonin adrenaline reuptake inhibitors. Then Lactaxine 75 to 300 milligram daily. Medication response may take 6 to 8 weeks or even longer. Patient with known history of depression or previous postnatal depression should have prophylactic antidepressants started immediately postpartum. The impact on the child, more negative attitudes towards their children, and the infant is less harmonious and responsive. Infant more likely to show anger, and at the age of 3 have behavioral problems. By the age of 4, they have cognitive deficit, and the high risk of developing depression later in life. Postpartum psychosis. We have the psychiatric emergency occurs in about 2 per 1,000 women following childbirth. 80% of cases present within the first 3 weeks of delivery, after delivery. Women with pre-existing psychotic illness are at highest risk, as well as those with prior episodes of postpartum depression. Symptoms include auditory hallucinations, delusions pertaining to the baby, agitation, confusion, disorientation, thought disorders, and changing mood. Management is to exclude medical causes of altered mental state, and we have to make a decision regarding whether to leave the mother and child together. Antipsychotics and stabilizers are used and antipsychotics, there's typical antipsychotics of chlorpromazine. So haloperidol exposure causes irritability, abnormal health swelling, extremity tremors, and chlorpromazine exposure causes extrapyramidal side effects or hypertonicity, tremors, motor restlessness, spasticity, and difficulty in sleep. You have atypical antipsychotics or risperidone, olanzapine, quetiapine, and clozapine. The mood stabilizers, they have anticonvulsants, sodium valproate, carbamazepine, and lamotrigine. Data from epilepsy registers indicate that these drugs are associated with high rates of media malformation. Then the first trimester exposure has higher rates of miscarriage, birth defects, your tooth defects or facial clefts, health restriction, cognitive impairment, and neonatal toxicity. In the first trimester exposure, there's a 0.1% risk of Epstein anomaly and increases birth weight and newborn hypotonicity and cyanosis of the baby, arrhythmias and hypothyroidism, and is contraindicated in the breastfeeding mother. A higher dosage of folic acid should be prescribed for women on anticonvulsants in pregnancy. NICE recommends that valproate should not be prescribed to women of childbearing age unless it is clinically justified on the balance of risk. So, a woman has been carefully counseled about the teratogenic risk and she is using adequate contraception. Benzodiazepines and sedative agents. Teratogenicity.
Presentation. Finish your son.
I will get into the syphilis.
Yeah, we're getting to the syphilis. Go to the you have to start with your a few slides of the syphilis.
Let's go to the.
Yeah.
Okay, just
Big things. What things?
Okay, syphilis, I think we know it's an infection caused by Treponema pallidum. Also, NeuorSyphilis was first demonstrated in 1913 by bacteriologist Hideo Noguchi as an infection of the central nervous system by Treponema pallidum. It occurs any time after initial infection with syphilis. Bacterial neuroinvasion occurs early in infected individuals due to failure to clear the infection results in NeuorSyphilis. So there's 5 types have been described: asymptomatic, meningeal, meningovascular, syphilitic paresis, and TEPS dorsalis. So asymptomatic and meningeal types are the early forms and occur less than a year from infection. Meningovascular is present around 5 to 12 years from infection. And syphilitic paresis and TEPS dorsalis, they are late or tertiary form and present more than 10 years after infection. So because in the epidemiology, in 2019, the global burden of disease study indicated prevalence has increased by 60% from 1990 to 2019, and 50 million infected individuals were recorded in 2019. The rate is steadily climbing amongst HIV infected and in males who have sexual relations with other males. It's 15 to 20 times greater than the general male population. 80% of new cases in the USA are amongst males who engage in sexual relations with others. So 50% of them also being HIV related. NeuorSyphilis has a 2 to 3 times higher incidence in Caucasians than in Africans, but Africans have a higher incidence of other forms of syphilis. It has a 2 times higher incidence in males than it does in females. So locally, in 1990, syphilis had a prevalence was at 10% in the general population. Asymptomatic management of STIs has resulted in a 30 to 40% reduction. ANC screening has resulted in a further 2% decline in 2015, and there's a higher burden of infection among adolescents, women accessing HIV prevention services, sex workers, men who have sex with and transgender people, and pregnant women and HIV infected. There's a high incidence in men and women presenting with genital discharge. Some of the risk factors are HIV infection, non-use of viral protection, male who have sex with males, multiple partners, and blood transfusion of urine. So the presentation of NeuorSyphilis, you have personality changes, dementia, cognitive decline, or behavioral defects at around about 83%. You have ataxia and gait disturbances, loss of coordination and disturbance, and balance. You have cerebrovascular accidents, visual abnormalities, stabbing type pain, urinary symptoms, and hearing loss. So classification of NeuorSyphilis, there's early or intermediate phase. The symptomatic NeuorSyphilis is the most common form and defined as suggestive CSF abnormalities in a patient with serological evidence of syphilis, but no neurological symptoms. Occurs before symptomatic syphilis or neurological signs develop, and patients are usually unaware. Then you have meningeal and NeuorSyphilis. Results from diffuse inflammation of the meninges. Symptoms are those of meningeal affectation, headache, nausea, vomiting, neck stiffness, photophobia, and seizures. And imaging may show meningovascular neurosyphilis. They have inflammation of the meninges and arteritis causing thrombosis and infarction. Early symptoms are non-specific, and symptoms depend on site of thrombosis. Spinal cord vessels may be affected, resulting in meningomyelitis and spastic weakness, sensory loss, and muscular atrophy. Then you have late NeuorSyphilis. You have syphilitic paresis, results from chronic meningoencephalitis resulting in cerebral atrophy. Symptoms can have a sudden onset and can be divided into early, such as mood disturbance, irritability, personality changes, alteration in sleep habits, and forgetfulness, and late, which is a libel mood, memory and judgment impairment, confusion, depression, agitation, psychosis, delusions, and seizures. Neurologically, the clinician may see ophthalmic abnormalities, dysarthria, and tremors. And you have TED stressalis, results from the degeneration of the posterior dorsal column and roots of the spinal cord. Classically, patients have an unsteady gait, balance issues, lancinating or stabbing pains, bladder dysfunction, paresthesias, loss of proprioception, visceral crisis, and visual changes. And the rhomboid test is positive. Additional neurologic deficits include agile Robertson pupils, ocular palsies, and diminished reflexes, vibratory and proprioceptive impairment, and Charcot's joints. Due to the lack of any existing definitive standardized testing. Testing analysis results. Early NeuorSyphilis will almost always demonstrate positive troponin troponemal and non-troponemal tests in serum or cerebrospinal fluid. Troponemal testing includes fluorescent troponemal antibody absorption, troponemal pallidum reticular agglutination assay, and troponemal hemagglutination assay, and the Zametic immunoassays. They are sensitive but non-specific in the cerebrospinal fluid and are usually positive for life, so they cannot be used for monitoring. The disease. Non-troponemal testing. In real disease research laboratory and rapid plasma reagent test decline over time can be used to track disease progression and response to therapy. CSF VDRL assay is considered the most suggestive single test for NeuorSyphilis if positive, and it has a sensitivity of 67 to 72%. PCR testing is very sensitive in detecting troponemal pallidum from primary chancres and moist secondary lesions, but is less reliable in testing the CSF for syphilis, and has not been approved for testing, say, syphilis in the CSF. Neuroimaging, it's helpful in diagnosis and management, but findings are non-specific. MRI is more sensitive than a CT scan. The may show meningeal syphilis shows left meningeal and cranial nerve enlargement. In meningovascular neurosyphilis, it shows brain infarcts on MRI, and tapestocells can have non-specific white matter lesions and myelopathic involvement. Syphilitic paresis may show increased intensity in the hippocampus, frontotemporal lobes, and periventricular regions. And coma will appear near the meninges as a lump of mass. That's it. These are some of the indications for lumbar puncture, untreated syphilis of certain duration, untreated or latent syphilis with a duration of 1 year or more. Patient with syphilis and neurological symptoms, ocular syphilis, demonstrated complications of late or tertiary syphilis with or without neurological symptoms. Before starting treatment for tertiary syphilis, especially cardiovascular or comatose. Lack of serological response to therapy, that is treatment failures, as indicated by not exhibiting a 75% decline in non-troponemal assays after 1 year. And then a serum RPR level of 1:32, titer of 32 or more after treatment, and concomitant HIV infection.
How much more is left? 10 minutes. I'm just wondering at this point whether this was NeuorSyphilis as we want to call it, and yet according to you, this is part of tertiary syphilis, and our patient was acute. And acute, you've got meningeal affectation, and it doesn't give you behavioral disorder. So as I listened to this, initially we all agreed, or we all thought this was NeuorSyphilis, but according to this presentation, NeuorSyphilis is a tertiary part, whereas meningeal, which doesn't give mood behavioral disorders, is part of the initial infection as we discovered with this patient. Unless we claiming that the
The meningeal and meningovascular are all part of secondary. So once you've got paresis, tabes dorsalis, or gummatous formation on CT scan or whatever, then that is referred to as tertiary.
Yeah, but that, I'm not sure if you're following my point, that here you're supposed to have, because she present, unless we claiming that the first RPR negative was a false negative, and then we pick up, because if she was really in the acute phase, which is primary, or the initial phase of syphilis, which is supposed to have your.
So the meningitis can be within weeks to months from the primary infection.
The what?
Weeks to months.
What is that?
From the primary, the second, the
meningeal.
the meningeal part of it.
Yeah,
Weeks
so
to
she
months.
wasn't, according to the test that we did.
So so there was a long period of time where she wasn't tested.
That's why I'm saying that the only saving grace out of this is to say that those tests were actually false negative, and maybe we missed.
She only tested at booking and then
Yeah.
the serum. That was it.
Anyway.
So yeah, I think I was also a bit puzzled because the behavioral on your case in the later syphilis, it doesn't occur in the early syphilis according to the presentation here. I mean, all this psychotic and what have you not, according to what you mentioned there, it occurs in the later.
With a patient with meningitis, you can have the delirium and that sort of thing. So yes, majority will come later, the dementia, more like dementia type symptoms, forgetfulness, but not acute psychosis.
Yeah. Did you mention acute psychosis in the early? It was not there. It only appeared in the later component of the NeuorSyphilis. It didn't occur. It didn't appear at all. But anyway, I think we have been educated. We need to think about it and be aware of now the only one thing I wanted to ask is so physicians often are reluctant to do lumbar punctures without CT. Who did the lumbar puncture was done at
we are the physicians.
So
we are the physicians as well.
You are the physicians?
Yeah, we have no physicians.
So did you guys do the lumbar puncture?
We do everything. We do pleural taps, acidic taps, we do everything.
Okay, because our physicians often before this, the lumbar puncture, they'll ask for a CT scan unless I'm mistaken.
Usually they complain about wanting to not.
Yeah.
I think lumbar puncture can be done if there's clinical indication, as long as you've done a neurological examination. There's no evidence clinically of an intracranial space occupying lesion. There's no difference in the pupils. There's no decreased level of consciousness. So I'm not quite sure, because I think that's one of the criteria. If you've got decreased level of consciousness, then they want to do a CT scan first. I'm not sure if she had a decreased level of consciousness or not. So if you've examined her, there's no evidence of a focal neurological lesion, and the level of consciousness is fine, then you're entitled to go ahead and do a lumbar puncture. Obviously, most places in the world don't have a CT scan at Heather. So
I mean, the CT scan was only done because there was no initial response to the penicillin. Then the symptoms persisted. So that was then the rationale for the CT thereafter.
Was no response to penicillin? How did
in terms of the symptoms, she became catatonic, and in terms of her psychiatric symptoms.
In terms of which penicillin? IV?
Yeah. So initially she took some time to respond, and they requested a CT brain.
So if we give penicillin, the behavioral changes would improve.
Yeah, and in addition,
with
she was an
time, but it would
I don't know
improve,
what, over what time,
Yeah.
but I don't know over what time, but
Mhm.
yeah, that, because she was also on an antipsychotic as well, so
Yeah.
antipsychotic with the penicillin.
Yeah, so if I can just comment, by the way, thank you for presenting the case. It's very interesting. So the primary syphilis, as you said,
Yeah.
is the primary chancre. Often asymptomatic. It can be inside the vagina. You might not even see it, so it might never be picked up, and it's painless. So after a few weeks, that disappears, and then there's a gap of a few weeks, or it can be months, and then you have the secondary syphilis. So the secondary syphilis is like a systemic reaction, and there are some typical features which we recognize, especially the rash, palmar rash on the soles of the feet. But they can be, any organs can be involved, including the brain, including the neurological system. But this will be quite a rare presentation. Sometimes, as you said, the NeuorSyphilis, if you were to test for it, you might find some signs, but it's just asymptomatic. So you wouldn't normally recognize any NeuorSyphilis as part of secondary syphilis. But in this case, it's probably the unusual case where there is actually clinical signs of NeuorSyphilis, but it's still part of the secondary syphilis. So it's still early, let's call it early syphilis, within the first year or so of the initial infection. And you can get other things like ocular syphilis can occur as part of the secondary syphilis, hepatitis can occur and so on. But they're sort of rarer findings. So in secondary syphilis, the syphilis test will always be positive. So the RPR was clearly positive. I'm still troubled by the fact that it was not picked up on the rapid test, because the rapid test should always be positive in secondary syphilis. So I'm just worried if you've got faulty tests, because that really is a problem, because we're relying on the rapid test.
Yeah.
So is the patient still with you?
No, she went across to psychiatry eventually.
Because I think, like, if we have a known case of syphilis, RPR is very high like this, or high, it would be good to just sort of test out the rapid kits that you have to see if they're testing positive or not on patients that we know are positive. Otherwise, we can't trust those tests that you've got, because you're testing every person at delivery. That's what should be happening.
Yeah.
If the test is unreliable, then to me it's really a big issue.
Sure. Okay, we've gone way over our time. Thank you everyone for joining us.
There's a consultant meeting.
Consultant meeting this afternoon.